And then the last one from this heat, also from the Mexican Pediatric Surgical Society, is Dr. Elsa Mariana Zúñiga Lara, and she is presenting incidence and risk factors for vascular complications in pediatric kidney transplantation, and she's coming from the Children's Hospital of Mexico, Federico Gomez.
Hello, my name is Mariana. I'm a pediatric surgery resident of the Children's Hospital of Mexico, Federico Gomez, and today I'm going to present you my work entitled Incidence and Risk Factors for Vascular Complications in Pediatric Kidney Transplantation. This work was made along with the transplant department. As you all know, kidney transplantation is the best treatment for end-stage kidney disease. Vascular complications are more frequent in pediatric kidney transplantations with an incidence up to 15%, which make them a frequent cause of graft loss. The objective of this work was to determine the incidence and risk factors for vascular complications in one of the largest pediatric series in the country. For this, we made an observational, longitudinal, and retrospective study of a pediatric kidney transplant cohort conducted at a single center from January 2012 to December 2023. We analyzed recipient demographic variables, donor type, graft characteristics, surgical technique, and ischemia times. An univariate analysis was performed. For quantitative variables, we use chi-square test, and for quantitative variables, we use a student t-test. The logistic regression formula was used in conditional mode to estimate the probability of each subject having vascular complications. During this period, 307 kidney transplants were performed with an average age of 10 years and weight of 42 kilograms. The principal causes of renal failure were unknown, oropathies, and glomerulopathy. There were 6 vascular complications, which means 1.9%, 2 arterial thrombosis, 2 venous thrombosis, 1 arterial bleeding, and 1 angle artery. 3 of the 6 vascular complications required nephrectomy, and the other 3, the graft was saved by early reintervention. Here we have the first 3 cases. In the first one, it was a venous thrombosis. It was in a patient of 40 years. It was from a deceased donor, and it required thrombectomy and next nephrectomy. The second case was an arterial thrombosis. It was from the same donor as the previous one, and also required thrombectomy and nephrectomy. The third case was an arterial bleeding. It was secondary to a suture dehiscence, which required operation, and the graft was saved. In the next cases, we had an arterial thrombosis in a patient of 5 years. It required thrombectomy, and the graft was saved. In the fifth case, it was an angular artery, which required operation on the same date, and the graft was saved. The last one, and the most complicated one, was a venous thrombosis in a patient of 5 years with history of thrombosis and thrombophilia positive and vascular exhaustion. It required thrombectomy, nephrectomy, and it sadly passed away. We analyzed the demographic variables, and we encountered that the vascular complications were present more in patients with low weight and with a history of thrombosis and thrombophilia. When we analyzed graft and surgical technique variables, we encountered that prolonged times of warm ischemia, total ischemia, deceased donor, a most proximal anastomotic site, and a transperitoneal surgical approach were the most related to developing vascular complications. Doing a logistic regression analysis, we encountered that the history of thrombosis or thrombophilia, transperitoneal approach, and total ischemia per minute were the most related to developing vascular complications, which allow us to create a calculator that estimates the probability for developing them, with a risk of 93.04% if we have the 3 variables. As conclusions, the incidence of vascular complication in our series is extremely low, 1.9%, which compares favorably with other kidney transplant series of other countries. The 2 most feared complications, arterial thrombosis and venous thrombosis, occur only in 0.6% of cases each. They were the cause of graft loss in 0.9% of the cases, and the risk factors associated with vascular complications were history of thrombosis and thrombophilia, transperitoneal approach, and total ischemia time. Thank you.
All right. Thank you so much for the presentation, Mariana. Meera, I think we have a question.
Yes, thank you so much. I'm actually asking a question from one of our partners, Dr. Alex Bondoc, who's one of our pediatric transplant surgeons, but is actually dealing with some transplant stuff right now. So in his stead, he commented on the fact that one of the challenges to pediatric transplantation is that there's such varied causes of end-stage kidney disease in different age groups, as well as all the size considerations to doing transplants in little kids. And so the perioperative hemodynamic monitoring and goals are really important for addressing vascular thrombosis. So he was curious if your institution follows a set of guidelines or things that you use particularly to guide perioperative management for CVP or blood pressure goals, et cetera, resuscitation.
Yes, well, in our institute, we try to conduct a very exhaustive evaluation previous to the transplant. All the kids have to pass for a series of analysis, checking all the variables that could prolong or could predict some of the vascular complications. And that was the fact that we created the calculator, so we can estimate the probability for having those complications. And we encountered that the principal three were the history of thrombosis that we analyzed previously, the prolonged ischemia times that have to do with the transplant, and the fact that they have a history of previous diseases.
Did you see any difference between deceased donors and living donors in terms of your outcomes?
It wasn't statistically significant, but we encountered that it is more common with deceased donors.
Fantastic. Thanks for a great study and for presenting today.
Thank you.
Thank you, Mariana. All right.
Thank you.
We are going to go to the poll now and pick the favorite of this heat. And so we have a lot about image guidance here from Dr. Lautz and also Dr. Ortega, some transplant and some neuroblastoma, a little bit of a mix. So let's see what people like. Looks like people are very interested in image-guided surgery, as those were the top two picks. So I do think this is obviously a very exciting emerging technology that people are wanting to hear about. I think it's going to change the face of surgery. So I think we can call it here. So Dr. Timothy Lautz on the ubiquitous folate receptor expression in pediatric and adolescent tumors using fluorescence wins this round. So thank you all so much. Congratulations to IPSO.